All right, let's get right into it. Today, we're tackling a true medical emergency, a condition that can go from just a few weird symptoms to a life-threatening disaster in literally a matter of hours. We're talking about a high-stakes medical puzzle where all the clues are microscopic and the clock is always ticking. This is thrombotic thrombocytopenic purpura, or as we call it, TTP.
And you know, the central mystery of TTP really boils down to this one question. How can something as small as a blood clot, so tiny you can't see it, cause such absolute havoc across the entire body, shutting down the brain, the heart, and the kidneys all at the same time? Well, that's exactly the question we're going to answer.
So to start solving this thing, you first have to understand what it looks like on the front lines, in the emergency room. A patient with TTP doesn't just walk in with a neat label on their forehead. No, they show up in the middle of a full-blown multi-system crisis. Everything is going haywire at once. And what makes TTP such a diagnostic nightmare is this clinical storm of symptoms. The patient might come in with a killer headache, acting confused, maybe even having a seizure. At the same time, they're incredibly tired and pale. That's the anemia, a severe shortage of red blood cells. You might see these tiny red dots on their skin, petechia, which are a dead giveaway for a critically low platelet count. And underneath all that, their organs, the heart, the kidneys, the gut, they're all under attack. And get this, fever, which you'd expect in something this severe, it's only there in maybe a quarter of cases. So it's a really confusing picture.
You know, for years, doctors were taught to look for this classic pentad, a perfect set of 5 symptoms. But here's the absolute kicker, and it's a huge clinical trap. That full pentad, it shows up in only about 5% of actual patients. If you wait around to check all 5 boxes, you've waited way too long.
So let's just quickly recap this first part. TTP is a full-blown emergency that looks like a chaotic, multi-system breakdown. The symptoms can be all over the place, but the 3 things you really need to zero in on are any changes in mental status, signs of that severe anemia, and a really low platelet count. Okay, so we've seen the what, that clinical crisis. Now let's dig into the why. To do that, we have to zoom way in, from the patient's bedside right down to the molecular level, because that's where the real culprit is hiding. So, I want you to meet the hero of our story, or maybe the missing hero. It's an enzyme called ADAMTS13. Yeah, I know, it's a mouthful. So let's just forget that name and call it what it is, a pair of molecular scissors. Its one job, its only job, is to patrol our bloodstream and trim another protein called von Willebrand factor, or VWF. Think of it like a little molecular gardener, constantly pruning these long, sticky VWF strands so they don't get out of control. And this image right here just illustrates the whole problem perfectly. Take a look at the left, in panel A. This is normal. The ADAMTS13 scissors are on the job, snipping those VWF strands into small, manageable pieces. Platelets just flow right on by, no problem. But now look at the right, in panel B. The scissors are gone. And look what happens. The VWF grows into these huge, ultra-sticky web-like nets, and they're just floating around, waiting to cause big trouble.
So let's just walk through this crime scene, step by step. First, the molecular scissors go missing. ADAMTS13 activity just tanks to less than 10%. Second, without anything to prune them, these sticky VWF nets grow completely out of control. Third, these nets are basically like flypaper for platelets. They just grab them out of circulation. Fourth, all this trapping creates millions and millions of tiny clots, what we call microthrombi, all through the body's smallest blood vessels. And fifth, well, that's the catastrophe. These tiny clots block blood flow to vital organs. They chew up all the body's platelets, and as red blood cells try to squeeze past, they get literally shredded to pieces.
And what's so amazing, so elegantly simple, is that this one single problem, one missing enzyme, it leads to the sticky nets which create the tiny clots. And that one single mechanism explains everything we see in the clinic. The low platelets, they're being used up in the clots. The organ damage, that's from blocked blood flow. And the anemia, that's from all those shredded red blood cells. It all connects.
Okay, so we know the culprit and we know the MO, but how do we actually prove it? All right, let's put on our detective hats and see how we follow the evidence to crack the case and make that definitive diagnosis. So the first clues we get are from the patient's blood work. As you'd expect, the platelet and hemoglobin counts are way down. LDH, an enzyme, is really high because it's spilling out of all those shredded red blood cells. And haptoglobin is low because it's a protein that's working overtime to clean up all the mess from those broken cells. Now look at those last two rows. This is critical. Kidney function is often pretty close to normal, and the standard clotting tests, they're completely normal. This tells us the problem isn't with the whole clotting system. No, this is specifically a platelet problem. But the most important piece of evidence, the absolute smoking gun, is what you find when you look at the blood under a microscope. Look at these. These are called schistocytes. They're fragmented, sheared, just torn up red blood cells. Some of them look like little helmets, others are just tiny shards. This is the physical proof that there's a destructive force inside the blood vessels. It's the absolute hallmark of something we call microangiopathic hemolytic anemia. And finally, here it is, the final, irrefutable piece of evidence that confirms it all. We send off a special test to measure the activity of our molecular scissors. And when that result comes back showing that Adam's TS13 activity is less than 10% of what it should be, bam, case closed. The diagnosis is TTP. So the diagnostic path is pretty clear, right? You suspect it based on the clinical signs, you look for that lab pattern of low platelets and hemolysis but with normal clotting times, you find those cystocytes on the blood smear, and you confirm everything with an Adam TS13 level under 10%.
So the diagnosis is in, and now the focus shifts instantly. This is not a time to sit around and think, it is a flat-out race against time. Treatment for TTP has to start within hours of just suspecting it, because if you don't, the mortality rate is close to 90%. The absolute cornerstone of treatment is a procedure called therapeutic plasma exchange, or TPE. What we do is hook the patient up to a machine that removes their plasma, the liquid part of the blood, and replaces it with fresh frozen plasma from healthy donors. And the impact this has is just staggering. This one single intervention takes a disease that was almost always fatal and turns it into one where 80 to 90% of people survive. It's a total game changer.
So how does it work? It's this beautiful, elegant 2-for-1 solution. First, by taking out the patient's own plasma, we're removing the bad stuff, those autoantibodies that are attacking the ADAMS13 enzyme in the first place. And at the exact same time, by giving them donor plasma, we're replenishing the good stuff, giving them a fresh, working supply of the very enzyme they're missing. You remove the problem, and you provide the solution, all in one go. Now, while that plasma exchange is running, we're also attacking the root of the problem, the autoimmune disease itself. We use powerful immunosuppressants like corticosteroids and a drug called rituximab to shut down the factory that's making those bad antibodies. And there's also a newer drug, caplazumumab, that acts like a shield, directly stopping platelets from sticking to those VWF nets. It buys us precious time for the other treatments to kick in. Okay, I need everyone to listen to this because it's so important and it feels totally counterintuitive. The patient's platelet count is dangerously low, right? But you do not give them a platelet transfusion unless they are actively having a life-threatening bleed. Why? Well, think about it. Giving them more platelets is literally like throwing fuel on a fire. You're just giving more raw material for those sticky VWF nets to build more clots, and that can make the whole situation even worse. So, to wrap up management, TTP is a code red emergency. The #1 treatment is plasma exchange, and you start it immediately on suspicion alone. It works by taking out the bad antibodies and putting in the good enzyme. You also use steroids to suppress the immune system, and whatever you do, avoid platelet transfusions unless it's an absolute last resort. All right, for our last section, let's look at the final piece of this puzzle. We know the problem is a lack of ADMTS13, but why is the enzyme missing in the first place? Well, it turns out there are two completely different reasons, which gives us the two faces of TTP. On the one hand, you have acquired, or immune TTP. This is the one we see almost all the time, over 95% of cases. In this version, the body's own immune system gets confused and creates antibodies that attack and destroy its own ADAMS13 enzyme. Then on the other side, you have the very rare version, congenital TTP. In this form, a person is just born with faulty genes and their body never learns how to make the enzyme correctly in the first place. It usually shows up really early in life or sometimes during the stress of a first pregnancy. So two very different paths to the exact same catastrophic destination. And that brings us to our final thought. So you've gotten a patient through this incredible crisis. The storm is past, but the threat isn't totally over. For people with the immune form of TTP, those antibodies can always come back. So the crucial question becomes, what happens next? How do we watch for the next storm? How can we monitor their Adams TS13 levels and jump in before a relapse turns into another life or death race against time?
That, right there, is the ongoing challenge in managing this incredibly fascinating and dangerous disease.